Yeah, so we were excited to present our results today. We looked at blood pressure guidelines and who qualifies for blood pressure treatment and who doesn't based on the most recent guidelines from 2017. And what was unique to those guidelines was a stronger incorporation of estimating risk for heart attack, strokes, heart failure. And so our question was, can we do better with estimating risk using some blood-based tests, some biomarkers that measure damage or wear and tear or stress on the heart muscle. And so those two blood tests that we used were a high sensitivity troponin assay and an NT-proBNP assay. And these are blood tests that we use in acutely ill patients, so people that come into the hospital sick with a heart attack or heart failure. But we also know that about 25% of people walking around who are otherwise feeling fine have subtle elevations in those markers, not to the level of a heart attack or a heart failure exacerbation, but detectable with these assays. So we employed those in large population studies according to the blood pressure guidelines. And we basically stratified people. Did they have an abnormal biomarker or was it totally normal? And we found a nice degradation of risk by those biomarkers, such that the people who were in the same category, not recommended for treatment, about 30% of them, or a third of them, had an elevation in one of those biomarkers, and their risk for events was twofold higher than those who did not. So by all other measures, they were at similar risk, but this biomarker actually identified people who were at higher risk than we thought, and potentially then may benefit from more aggressive blood pressure treatment, medications, or intensive lifestyle modifications. So I think you raise a great point as to, who's the right population for this. Is have we really tapped into this test and the research, sort of the information that you can glean from this test, specifically the troponin assay, which we've all become very comfortable using in the acute setting. Someone comes with chest pain, helps us decide, do we think it's a heart attack or not? But now the concept of measuring this in healthy people who are walking around not presenting with any symptoms, what's the right group to use a test like this in? That's not something we can fully answer with our study. I think my own clinical practice with the data that we've generated, oftentimes I'll have patients who are unsure about starting medication for a risk factor, blood pressure. In that discussion and in sort of motivating that patient to how aggressively they need to be with their treatment, this is one of the tools now that I think we can incorporate into that discussion and say, listen, I think you should be on blood pressure medicine. You don't think you should be on it. Maybe we should check to see if there's any subtle wear and tear that we're seeing the early signs of with one of these markers. And if it's there, then we really need to, be more aggressive. Alternatively, if you have someone that I may think needs to be on blood pressure medicine and they're not quite ready or sure, and we test this and it's a little bit high, that can really identify, hey, you know what, we may be underestimating your risk, but now we're seeing some risk factors, some actual consequences of these risk factors. And not only blood pressure, which is what our focus was in, but certainly treating the whole patient, the lifestyle modifications, exercise, motivating dietary changes, weight loss, all of those things I think can be achieved if you have this kind of result. But deciding in whom to measure it in is still a question that, it's not one that we would say measure in everybody, because we don't have the data to suggest that there couldn't be harms from that. So you really want to understand, have a discussion with patients about what you're going to do with the results before you test.